today. Today we have two speakers, Dr. Holly Martin, who's an associate professor here at UCSF in pediatrics. She's also the director of the San Francisco General Hospital Pediatric Nocturnist Program. She's been doing amazing work in Peru, basically, I think, since medical school, right? Your entire career. And is one of our kind of consistent and fantastic pathway mentors, and has mentored several of our residents previously. And then Dr. Angela Hermosa is a professor in the Faculty of Medicine at the Catholic University of St. Mary's in Arequipa, Peru. She's also the director of the health center, Mariano Melgar, and she's been working in public health and primary care since 2002. And she and Holly have collaborated on many projects together. So I will let you guys go ahead and take it away. I can monitor the chat for you, so don't worry about that.
Okay, perfect. Let me just start sharing my screen. Okay. Sorry, I'm going to do it the basic way. Thanks to all of you. I'm just like looking at everybody. Thanks to you guys for joining. It's always nice to see people's faces pop up. I am so happy to be here. Okay, I do see. So I've met like a surprising number of the interns who are in the global health track already this year. It's like amazing. So shout out to those of you who I've seen on nights recently, Doris, Amira. I am so excited to be here with you guys this morning. This is like one of my favorite things in the world to talk about is my experiences and time that I have spent with Angela and others working on global health in Peru. And so I'm really happy to be sharing some of that with you all. And I'm just going to dive right in. So this beautiful picture is Arequipa. And I have been going there since 2005. I just want to talk about my kind of pathway in global health and how things have kind of evolved, where I kind of different things lead to other things. And, you know, that was almost 20 years ago, 19 years ago. And I also wanted to talk a little bit about how Angela and I have been collaborating over the past 10 years, because I think that's been so much of what's been important to me and being able to have our partnership. And especially since I've been back here full time in the US. So basically, I'm just gonna go over a little bit about how I got interested in global health. I, wasn't even in medicine initially, and then decided to leave publishing and go into medicine after I was in New York on September 11th and kind of had a 22-year-old life crisis of, oh my gosh, what am I doing with my life? Really thought about that. And then after getting into med school, I was at Columbia, and Jeffrey Sachs is this great economist who does a lot of health stuff. And he's at Columbia, and I heard him give a talk when I was a med student there about childhood, the burden of childhood diarrheal disease, and how that was one at that point in the early 2000s was one of the highest child mortality drivers across the world, and how it really just shocked me. And so I started thinking about doing work on that. And simultaneous, I think that was probably at the beginning of my second year. But the summer after my first year, I'd actually traveled to Peru at the urging of one of my good friends in med school, whose parents are both Peruvian, and she grew up going there because I had wanted to work on my Spanish. And when I was there, like my 5th day in Peru, I met my current husband, Jimmy, and we hit it off, traveled all over the country together that summer. And then when I went back to med school, we were in a long distance relationship. And I would say, obviously, if it weren't for my relationship with him, I am sure that my global health career would not have been in Peru over the past 20 years. So it's been very much a kind of like a merging of what my professional interest in global health, along with a very deep personal connection to Peru, and the time that Jimmy and I like spend in Peru, always traveling back to see family and stuff. And then it coincided with being able to do projects and work and all of that. So especially as a resident with such little time, it was always like a vacation, which compared a little bit of global health work as well. So I took a year off in med school, and that's what the 328 Peruvian Mothers is. I basically designed a large door-to-door interview that I did with that many women about diarrheal disease in children, and wanted to learn kind of what they thought diarrhea came from, what they typically used to treat it, what they'd been told by community health workers. And all of that was in 2007. So now it's like a really long time ago. And if you look at the global, at Peru's like UNICEF data for mortality, it was still a really humongous problem. But what really interested me in my analysis of those interviews after the fact was that if they had been counseled by a community health worker, they were much more likely to have used oral rehydration solution. And that really cemented for me the importance of health education and how significant it was. And this was, after my third year in med school. So I had done some clinical rotations and stuff, but it was very early in my medical training at the same time. And so and I did every single one of those interviews myself and walked door to door, knocking on doors. And, basically that was my entire year. And it was very formative for me, because I think that it made me realize like every single statistic, there's actually a massive story behind it with each person and family, and how far that education piece, where if you explain something and explain it well, and people kind of become to understand it, then it can make such a difference in health behaviors and ultimately in outcomes. So I really kind of took that with me as I thought about what else I wanted to do. And then when I ended up at UCSF, I was one of the plus residents. Kind of thought a lot actually about global health track versus plus. And it's funny because now, like the two people I talked to as a med student trying to decide, Chris Stewart and Anda Kuo, who ran those two programs back then, are still my colleagues at the general now. So it's kind of amazing. But anyway, ended up being a plus resident, which worked out well for me. And I also was able to then go on trips. Like I said, when I would have vacation, sometimes I was even able to pair it with a call for elective with vacation, and go down to Peru with the family. Me and my husband it was the Great Recession then. And so we had kids during residency. And anyway, what we would do is we would move out of our apartment, put all of our belongings in storage, because we were like, we can't pay rent for 6 weeks while we're not even here. And then we would come back, get a new apartment, and move all our stuff back in after those 6 weeks. So maybe it was a precursor of us actually moving to Peru full time. But basically, from the time I was a resident, I set up a nonprofit down there, which was my first vehicle for having people go down. I had co-residents go down to Peru. And a social worker at Berkeley who was also really interested in global health. She went down and did a project when I was a resident. And then when I went on to faculty at the general, I kind of took on that role, always knowing that I wanted to continue my work in Peru. So I ended up deciding not to do primary care, and I would do urgent care and inpatient work at the general, where I worked full time. And at that point, everything was kind of in my extra time that I had on the side. As time progressed, I would continue to work frequently with residents in the global health track, but a lot of what my ultimate goal was to try to get a little more traction and be able to have more time in Peru. And Jimmy and I's ultimate goal had been that we wanted to be able to have our, at that point, 2 kids live in Peru full time, just as a family, as a bicultural family. It was important to us that they understood like being Peruvian in the real sense of living there, being with all the family, having that, going to school, having all their friends there, everything like that, instead of just being visitors. So we were able to do that when basically in 2017, 2017, we were able to kind of move down full time, and I kept working clinically at the general, but because I'm a hospitalist, and at that point I had started the nocturnist program there, which meant I work nights, I work inpatient weeks, and I'm able to have all of my time kind of consolidated. I'm also a case arc call person there, so actually I could like stack all my jobs on top of each other and be on call for case arc and also be ward attending, and then throw some nights in and do one random urgent care shift. And my family was all in Peru, so I didn't have anything else that was needed of me. So I just worked like crazy. So I would travel up, work for like 7 to 10 days, and then spend all the rest of my time in Peru, which just made, I mean, I don't know if you felt this way, Angela, but it just made me feel like it was night and day from my intermittent trips, and the way that that would feel in my work. And then I'm going to move on from this slide, but this, I just realized I had other slides for describing all of these things. I'm gonna go backwards really quickly. So this was the association between teaching from the health center and the maternal use of oral rehydration solution. You can see that when they got health education, it was 66% versus 34% when they didn't. And then if they hadn't gotten health education, it was much more lower used. And then over those years that I'm describing being an attending, and this kind of carries forward into those years that I was living there, we had tons of different projects that people would work on. This is the view, by the way, from my house in Peru. And this is the volcano that looks over the city, and it's just, I think, the most beautiful city. So this is a picture of Hannah and 2 of the medical students who helped her. She was a medical student who actually did work on one of our studies that I did with Colin Partridge, who's now a retired professor at UCSF. But we were looking at disability and thoughts about disability, and wanted to look at all different countries. So it was Peru, Vietnam, Haiti, and then Kenya. This data was originally collected in Kenya, but we added 3 more sites. Just really trying to get a sense of how significantly different attitudes towards disability, both mild and severe disability, are in countries across the world. We would also do work with the Department of Public Health on adolescent health. So Christina Herrera, who then went on to, she's now at CHOP in the adolescent department there, and Holly Vo, who was also a UCSF resident, did adolescent health surveys, working with the Department of Public Health and trying to do kind of like needs assessments with teens at different clinical locations. We've worked a lot with Angela on anemia, which is a huge target for Peru, for the pediatric health, and a lot of different things were done there. One of the CHO residents actually went down and was helpful in starting some PDSA cycles in the clinic where Angela was working at the time, thinking about different ways that we could troubleshoot a lot of the systemic and logistic problems, along with just getting parent buy-in and creating some of those health education tools, which are so important for really creating behavior change in families. And then one of my always top of my list goals is working on improving both the childbirth experience for women, but also neonatal resuscitation and survival. And I've had a long-term project which ebbs and flows of an app, a smartphone app that guides people through neonatal resuscitation in real time, to be used in lower resource areas where there's less experience, or people who have less experience attending deliveries. But this study was actually one of the global health master's students. I had two working with me simultaneously, and Brianna's study was qualitative interviews about childbirth experiences, both in the urban area in Arequipa, and then also interviewing women in this rural area, which is about 3 hours away from Arequipa, in Cayuma. So she did this excellent project as her capstone, ended up getting it published, and was just really interesting presenting that work back to the Department of Public Health that oversees, and realizing how much work there still is to gain the trust of the population based on some of the experiences and birth trauma that the women have experienced. Here's a lovely picture. So we have worked with the Universidad Católica, where Angela is a professor of medicine, on a lot of different work. They created a sim lab, and which was fantastic, but really didn't have a curriculum. So we worked with them specifically on creating some like pediatric curriculum, running some simulations, and getting that done. And we had some other students who were there working on that with us, both from Fresno and then from our UCSF Peds residency. Here's a picture of some horrible bus exhaust. There's like, you know, mass transit in the buses, but it's actually maybe the like worst contributor to the pollution. But this is an old picture. I feel like the buses are getting better, but the smog is still a humongous problem just because of the number of vehicles has increased, the population increase, and a lot of those older cars have much worse emissions than newer vehicles. Also, as the economy has increased, foreign companies have come in, including, you know, fast food, and there's just, you know, a kind of corresponding increase as Peru has changed into a middle income country with worsening nutrition in the form of like poor nutrition leading to obesity, increased diabetes, access to fast food, which is so unfortunate, but definitely something that I think is really relevant to think about kind of like sooner rather than later within pediatrics, so that we aren't trying to like make up for lost ground in the way that I feel like we're battling in the United States on that. And then, so basically, I think that as I spent more and more time in Peru, I became more and more like, I've been there long enough to see all of the ways that not just Peru, but really I should say Arequipa, because that's the city where we lived when we're there. It's the second largest city in Peru after Lima, but it's like 1 million people. And the ways in which it's changed since I first went there in 2005 are hard to believe. It's almost like I want photographic evidence. But I remember it. So, you know, there was one stop sign. There was like one intersection that had like a green, yellow, red stoplight at it, and that was it. And there was like almost 1 million people living there then too, but they just, you know, I don't know, they didn't need them. And now they have, it's like a silly example, I guess, but for me, it's like kind of emblematic of how significantly things have changed. There was one kind of like department store of a Chilean like department store, and that was next to the one movie theater, and otherwise there wasn't anything. And now there are, I don't even know how many malls, like a ton of kind of like change in the economy of the country, which those are kind of the ways that I saw it evolving. A lot more newer vehicles on the roads, just amazingly different changes. And this second graph is from 2011, so it's just still almost barely capturing a lot of the change that I've witnessed over the years, but you can see how dramatically things have changed for Peru over the past like 35 years. This is more graphs just like thinking about that. And I think that the way that this almost always those changes in economy of a country are then reflected in improvements in the health of a country as well. And so in thinking about how much the economic situation has improved in Peru, you can also see that that the life expectancy from 2000 has just like gone up a lot. The child mortality has improved as well. The immunization graph here I included because I kind of want to ask, I didn't get a chance to ask Angela before, but this is a new slide for me, and I'm like, not really sure what's happening with that, if like the timing is off and they're later, because it's very specific at the 12 to 23 months. So it might be that kids are getting it late, but it's, not exactly going in the right direction. But I think that one of the things that I think is really important is realizing how like certain aspects of the way the society ends up taking those changes in their economy and applying it to the population. Peru has been in the news over the past several years for, a lot of instability, some degree of societal instability, which, got headlines for whatever reason, but definitely, I think has been like post-pandemic, especially having a lot of difficulty with the sort of like seismic shakeup that was caused by that, and then kind of the fallout afterwards. So I think that this particular slide is just interesting to me because that health and education and infrastructure are several things which are lagging despite the improvements in the income, and the ways in which those things can play catch up. The potential there, I think, is maybe the sort of other way of thinking about it. And then this is all-cause death in Peru, and I definitely like anybody who likes looking at graphs and data and kind of like playing with the numbers, go to the UNICEF data country website for any place that you're interested in exploring, because you can really like hash up that data in all different kinds of ways and really like drill down on trends and see different causes of mortality. And when I was playing around with it, one of the things that I noticed most recently is just the degree to which the birth asphyxia and trauma has really stayed almost steady compared to the decreases that have happened in other situations, which makes me want to revive the neonatal resuscitation app again. And just for a little info about that, so like when you look at neonatal mortality, which is the like earliest markers, the breakdown actually of when those under 30-day-old infants die, and you can see that almost all of it's on day 0 or day 1. And then it really declines from there. So when you have that happening, you have to realize that so many of these things are simultaneous, and if there's any pretermness of the infant, the death is going to be deemed because it was preterm complication and not intrapartum, but they're still all happening in that first 1 or 2 days of life. And if you think about that proportion of the 44% of under 5, then 44% of them are neonatal, and how much of that is happening in this like very short time period, that the way that interventions very acutely around birth could be so effective, I think is really compelling. This number is from several years ago, but I think that you know, there's been a lot of like shakeup with the pandemic in terms of birthing practices, and we saw that even in the United States, and it kind of went through the whole world in terms of the difficulty of having hospital-based births, especially in acute phases. But this is one of the initial comments that that we had as we were doing our study on one of the trials of the app. This is a midwife at one of the at Mariana Melgar, actually. So they the midwife had a woman with prolonged labor. The baby was born really floppy. They tried to resuscitate, warm, dry stim. Basically, you can see rubbing the feet and the back. And then at the 5-minute APGAR got better. And then they had talked about it and realized they were supposed to do bag mask ventilation, but nobody was even aware of that. So while health education for parents is important, there are certain things where just creating institutional procedures and training and simulation, and then potentially like real-time support can go so far. This is more about the training, kind of go past that. So this is an early version of the app that I'm talking about, but we tested it and the outcome was really successful in some of those clinics where they do deliveries. Having the app improved their use of PPV in the first minute, improved the success of the PPV, and was much better than just the control where they didn't have the app to help them. And people liked it as well, didn't find it intrusive. So I'm gonna, in the interest of time, I think I'm gonna skip this slide. Oh, that's a interlude picture of my now 6-year-old in our living room looking out our window in Peru. But I wanted to like spend just my last little bit talking about the collaboration that I've had with Angela, and the way that that's informed so much of the work that I've done. Because I think that as you're thinking about global health, I think it's really important to never try to do it by yourself. And so I was like looking back, because in order to create this slide, I was like, when was it? Like, when did we start working together? So I searched my emails, and because I never delete any email ever, I was able to find like our very first emails back and forth. And Angela and I were introduced to each other by another fantastic colleague that I had really more of a mentor, Braulio Cuba, who worked in public health in Peru and then went on to work at stuff in the national level and was in Lima. But he had originally been in Arequipa, and I had been introduced to him by my sister-in-law, who knew his administrative helper, who then made the connection for me, and that's how I met him, actually. But then, you know, I had reached out to him in 2014 about another idea, and he at that point was in Lima already, and he then got me in touch with Angela. And since then, it's just been a constant collaboration. And I think some of the pieces that I really appreciate about our collaborative relationship is that we both have a lot going on all the time. Angela, I think you are one of the like busiest people with the most hats that I've ever seen in terms of your professional responsibilities and things, and constantly evolving as well. And I do the same. And I think that, like, you know, sometimes I'll go like 3 months without talking to Angela, and then we'll hop back onto our text chain, and I'll find out that she just got, you know, named to be the head of a massive private clinic in Arequipa, and she's like running this humongous hospital. And so that's why she's like, I haven't been able to talk to you because I am suddenly in charge of this humongous thing. Or like she becomes the head of the physicians group monitoring the ethical, or what is the way I would describe it? Kind of like the doctors association for the entire country of Peru. And you know, I tell you this because she will not mention it herself necessarily, but the ability for it to kind of like ebb and flow, but always just pick up wherever we left off, and keep working on things together. And I think that when I am trying to like I have a trainee who's interested in going, I'll like touch base with Angela and find out what are some of the things that are highest need, highest priority, what are or if somebody has a specific set of interests, then I'll go to her and say, within this subset of possibilities, like somebody's really interested in, you know, doing procedures, or like doing sim, or creating health education, or like whatever the kind of skill set that a trainee is interested in. And we can usually brainstorm together and come up with some sort of thing that is both very high on the list for the community in Peru, but also fitting with the interest of the trainee who's going to be going down. So it's just I just wanted to kind of like end my little section on that, because I think that without this long-term working relationship with Angela, where you know, we just talk to each other all the time and see each other, and she's even come up here and visited me, thankfully, because I am down there so much, but you're able to come up and see San Francisco and all of that as well. And I think that the strength of that is the basis of how I've been able to carry on, especially since having to relocate back to the US, and trying to figure out how to continue work after losing the sort of constancy that I was able to enjoy living there full time. So I'll kind of end there and say thank you, Angela, for what has been now 10 years of us working together, which is kind of amazing. That's I'll let Angela go, and then definitely there's my cell phone, there's my email. Feel free to reach out to me if you're interested in working in Peru. I love talking with everybody about their different like global health goals and ideas. And I will say, like, especially since I'm not down there full time, the one caveat is like, if you are not able to speak Spanish, it will make everything a lot more difficult, especially if I'm not there to kind of like help guide you along in person. But thank you all so much for having us. And hopefully we can have a little chat, discussion, questions at the end after Angela's done. All right, I'm gonna stop my share now.
I continue or we expect the questions?
I think go ahead and do your presentation, and then we can do the questions at the end. Does that sound okay, Teresa?
Thank you, Holly. Is it okay? Okay. Hello, everybody. Thank you, Holly, for such a nice words about our work. Thank you. I'm gonna talk about Peru. Peru, like is in the map, is a country in South America. It's here. And Arequipa, it's the city, the department where I live. It is here in the south of Peru. Have a part of it in the coast, also part of it in the altitude. Arequipa city, it's about 2,300 meters up the sea level, so it's more in the altitude. The health system in Peru, we have three big systems, three big levels. That it's the first level that include medical centers, which this receive the usual consultory patients for take care of them of vaccination, pregnant women's control, um, mm, control of diseases like diabetes, some chronic diseases, but they don't have operation rooms. It's only consultories, and usually it's open 12 hours a day, and only some of them opens 24 hours a day. These are the biggest medical centers that assist deliveries of patients. And in all Arequipa, it's around 5 big medical centers. The level it's called 1-4, and they are like the contention to the hospitals. In the second level, we have the hospitals. I mean, the difference is that they have operation rooms, but in Arequipa, we in all the system we have like four hospitals in the second level in the public system. But in the private system, now we have like 3 hospitals that we call it clinics. And in the third level, it's are the institutes that are more focused in some diseases, like the Institute of Children, like the Institute of Oncology Diseases. And in all the country, we have 12 national institutes of health. I mean, it's the highest level of complexity to see patients. So now we can see in this picture how it's the numbers of medical centers of or hospitals. The basis of this triangle, it's the first level. We have more medical centers to assist consultory or prevention assistance to the patients. And the second level, the hospitals, and the third level, the institutes. To see the situation of the insurance in the country, it's something very important for us. One of the objectives of this millennium, it is that everybody in the country has an insurance. I mean, universal insurance. And we have to say that after pandemic, we improved a lot this number. In total in the country, we have more than 36 million of people in the country. And nowadays, we have more than 35 million people with an insurance. I mean, it's about 97.64% of the population has a kind of insurance. It means they are protected. And nowadays, in 2024, even it is improved to 98%. We have this kind of insurance in the country. I mean, the social insurance that take care of 70.6% of the population. This is a kind of insurance that it's free for the population. It doesn't matter if it's a Peruvian or not Peruvian, because we have a big immigration in the last 5 years. So they are covered also. That's the idea that everybody has be protected by an insurance. Before the pandemic, to enter to this insurance, we had to make a socio-economical evaluation. in the medical centers. As I mean, we have to go to the houses to see and to prove that this patient or this family needs the free insurance. But during pandemia, because of the emergency, there was a law that everybody can have this kind of insurance. They have to do is go to the medical center and present, and they are going to be activated their insurance. It doesn't matter if the family or the patient has money or not. It doesn't matter if it's Peruvian or not. Automatically, they have this insurance, the social insurance. So now we continued it with the same way. I mean, everybody can have this insurance. And after that, we have the e-salud, like 29% of the population has this one. This means, this is for people who has official work, I mean, a regular job, and part of it, the enterprise pays this insurance. I mean, the amount it pays to e-salud is bigger. So for that, it's only the enterprises who has a good economy and are regular in the system can hire these people, these employees, and they cover with this insurance. The APS, it is like private insurance. So it's only a few people, 3%, that has this one. People who wants to pay directly to the insurance company can have this kind of insurance. The other one, it's the army, the force, the police area. I mean, all the people who work for the army and police area, they have this kind of insurance. It's much less people, but they are connected with e-salud and with a CIS. So they are covered also by these two. And there are others that are very small, but very small one that is also the percentage is very small. So we have only very few people who is not covered, and it's because maybe they didn't go to the medical centers to register their insurance. So that's something that it was good after the pandemic, that we could cover all the population so they are not unprotected. In some way, it's not a perfect insurance, but they have a good protection, at least the biggest or the biggest diseases, surgeries, or even oncology diseases, they have a part of the treatment that is covered by this insurance. The sanitation situation, as Holly said in the presentation, the economical situation in the country improved in the last years. Here we can see from 2010 to 2021 how improved all the basic services like water, with chloro, with electricity, telephone, education, mortality in mothers and child mortality. We in this area, in these indicators, we increase, but also because of the registration in the medical centers in all the country. We improved the registration by with the technology, because it's not that it increased the totally the mortality, but also they are more in the system. The people, I mean, the medical centers or the the healthcare system arrives more to the altitude patients, so they are registered in the system, because now they have this insurance that is free. I mean, the patients are not going to pay, so they trust more in the medical centers to go, and they are not going to spend money. So they are more, we can focus and we can supervise their situation. For also they are better, we have better registration of them. This is a picture which shows how many medical centers we have in the country. For example, I'm sorry, this is how many people also or professionals we have in the country. we're going to say that, for example, we have more than 31,000 nurses working in all the country, more than 24,000 doctors working in all the country. I mean, we have more nurses than doctors. And medical centers or clinics in the third level, we had 34 in all the country, 141 hospitals, and 7,942 medical centers in the first level. I mean, this is the basis of all the health system that make prevention and curative, but only in the first level of the diseases. This is also a picture that can show how are the professionals in the country, how increase the numbers of workers, professional workers. And in this line, we have the odontologists that almost didn't change during these years. The obstetricians are in red, in the red line. Midwives, I think you have to know like midwives. They only see normal deliveries, I mean, with not risk factors. In the blue one line, we have the number of doctors that are having increased in the last years. And in the light blue, it's the nurses. So we can see how is the distribution and how they were increasing during the years. We have to notice that this number increased also because of the economy improved. Because these numbers of professionals are people who has a salary, who are in the system. So we can identify and see how many of them are working in the country now. But also, we must say that, for example, in this period 2011, only these people was hired by the system, but there are a lot of people that was in the private area. I mean, it was not in the system because in the public system we didn't have enough economy to hire a professionals or personnel in care area. But as it was improving during the years, we could hire more and more obstetricians, doctors, and nurses like this. Here also we can see some numbers or some percentage of the national budget. We can see that, for example, until 2020, more percentage was focused in the hospitals and less in the medical centers. Now this is changing. We hope that this change more. Also, how it was the distribution of the budget. For example, we can see here that in the rural area is much less than in Lima, for example, or that urban area. I mean, it was also some disproportional the distribution of the budget during the country or according to the areas. And also, we can see here that the payments of the salaries was bigger than the medicines or other instrumentals for the medical centers. So also we are focused that it's also changed. Now we are focused that medicines has to be enough for the patients in the budget. And here we see again how it's the level of attention in healthcare for our patient and how it's the distribution of medical centers, hospitals, or institutes. We have failures in coverage and access. For example, in this graphic, we can see since 2012 to 2020 that, for example, this area in blue, in dark blue, we can see that in 2020, for example, the pharmacies, I mean the drugstores, they were more, the patients prefer to go to the drugstore to get the medication immediately instead of go to the medical consultation. So during the years it increased. And the first level, it decreased. Now in 2020, it decreased the consultation of patients in the private consultories also. In e-salud, the other insurance system also decreased. Clinical, it's the private area also decreased. Means a hospital, I mean the public hospitals, it's almost the same. And we can see that that's something that worries us because the pharmacies of the drugstores receive directly the patients and they give medication like antibiotics or any medication without a medical evaluation. We have to say that according to the law, it's not possible they do this, but they are doing this. I mean, the reality is that the patient go to the drugstore and ask for amoxicillin and they sell it without any prescription. And only the pharmacy or the drugstore wants to sell the pill, sell the antibiotic. It doesn't matter if the patient has or not an evaluation. So during the pandemic, we have this big problem because all the hospitals and medical centers were so crowded and many people goes directly to the pharmacy or drugstores, and now it continues. So the government is trying to control this, trying to make some economical punishment to the drugstore, but we have still this problem. This is my medical center where I work now. Like Holly said, I was working in a very small medical center before when we met, in a very far area, like 40 minutes, 30 minutes from the city. And it was in that time a 12 hours medical center. But during this year, during the pandemic, they asked me to change. And so I passed to this big one. This is a 1-4 medical center. It means that assists people 24 hours a day, assist delivers for patients. And we have like more than 110 people working here. Well, and now I'm the director of this medical center. I'm very proud of it because we're advancing. And I remember when we were doing the researches for the patients with Holly, this is one of them that we visit, and we could make the research with the doctors, with the midwives and the nurses. This is inside. During the pandemic, they improved it because we have more budget to improve the medical centers, the biggest one. So the government gave money to do it, so it improved a lot. Before it was not like this, but after pandemic, it is like this. I mean, improved a lot. So during the pandemic in Peru, the budget were bigger, much bigger than other years. Nowadays, we have like doctors, nurses, technicians that continue, that they were hired during the pandemic, the emergency, but they are continue with their contracts. Much less salary. I mean, for example, a usual doctor like me, before pandemia, the salary was around 7,000 soles, that it's around like $2,000, more or less $2,000 or something more. And during the pandemic, they were hiring doctors for like $4,000, more or less a month. And they were during 2020 with that salary. But obviously, they were in the front, I mean, in the emergency areas, in the hospitals, in the medical centers. They were, I mean, the doctors just for COVID areas. After we finished the emergency last year in 2022, they changed the contract and they become to the amounts before pandemic. I mean, these doctors have a less salary than the regular doctors, but they have how do you say it, not end contract. I mean, it's a for until they retire, it's a contract. So that's good for us because now we have more doctors, more nurses, and more technicians working in the medical centers, in the hospitals, and we improve our services to the population because even because of even in spite of that, we have a lot of population that have not attention during the day or during the week. They have to wait a lot for a medical consultation or a medical procedure or surgery, where still we have demand of patients that is not covered by the system, but it's less than 2019, for example. And this is my city. It is also picture the volcano Misty, and this is the cathedral in the city in Arequipa. And we're very happy that I'm very happy that I could meet Holly, 9 years ago, and we improved a lot. And I have to say that it helped a lot to refresh. I mean to move the capacitation light for the doctors, nurses, technicians. They like it a lot. We like it a lot, the intervention with the group from San Francisco University. And we hope you come back soon, Holly, and that also the residents are welcome. Whenever you want to come and continue, we wait for you. And thank you very much.
Oh, thank you all so much. I love it. And also, this is the first time too that we've gotten to see kind of this overview of the child health in Peru. I think previous years we focused more on the COVID pandemic, and so this is just like a wide sweeping situational like awareness. I'll open it up to questions to those on Zoom. Feel free to come off mute or put your questions in the chat. And then we've also put a link to a survey, very brief, 3 questions long. We really do appreciate your feedback if you wouldn't mind doing that. So what questions do people have? Can I ask, maybe this is a question then for Holly and Angela. There were like multiple things that you guys kind of talked about in terms of just thinking about like potential projects for residents and how they can get involved. Sounds like there's like public health interventions that are still an opportunity. It sounds like the app for neonatal resuscitation, it might be an opportunity to revise that. What are kind of like, if you had to prioritize from like a local needs assessment, what would you say are kind of the current top 3 priorities in your mind?
Angela, based on our most recent conversation, I think anemia was definitely way up there. And I think that like, given Angela's position as the director at Mariano Melgar, there's a lot of potential for intervening in that location because it has a large catchment area. It's one of the really large sites. And besides anemia, what else would you say is in the top of your priorities for pediatric focused things?
If I understand well, is which other diseases we can focus in this medical center. Well, yeah, you're right. Besides anemia, because now it's a national policy, the fight against anemia. We have no transmission daños. I mean, like overweight patients, the vaccination system, because during the pandemic, because of the biosecurity and the social distance, the vaccination chronogram was affected. I mean, the people didn't want to bring their babies to the medical centers. They were afraid to get contagious. Even they even didn't want to receive the nurses in the houses because of be afraid of COVID. So all our goals in vaccination were really down, and now we are improving it. And so now next week we have a campaign, for example, against sarampion. I don't remember in English.
No.
Yeah. So we are starting again for 1 or 2 months because also we have goals to arrive. But we're improving. Last year it was a good year. This year we're improving more. And now we have a big worry also in the medical center, but it's also in the country. It's because the deliveries decrease a lot in the public system. I mean, it's the planification improve it, but also people like the economical situation improve it. They prefer to go to the private clinicals. So we are trying to focus them to not spend money because it's free if they go to the public area, but they are still with some, I don't know, psychological fear that they can get any disease in the hospitals or medical centers, and they think the private it's better and they feel more comfortable. That's something that now we're having. We have less deliveries, so we are not promotion and trying to make a good supervision, domiciliary visits to the patient, and focus also in the childs that may be well controlled, or in the clinic or in the public hospital, doesn't matter, but they go, that they don't fall the vaccination or they grow the controls.
Thank you both very much. And then Holly, oh, sorry, I didn't mean to cut you off, Holly. Go ahead.
Oh, no, that's okay. We're probably out of time. I was just thinking about what you're saying about them not wanting to deliver in the public setting, and like the situation of like how the deliveries are at the private versus the public, where like public hospitals don't always allow a support person to be with the person who's laboring, and the private sections usually do. And I wonder if some of those changes will trickle back down into like the large public hospital, especially where space has limited the ability to make it a more positive birthing experience for people.
Yeah, it's something also because of the economical situation. They can pay now the clinics. And an example, I always say to the students, for example, in 2005, a house, an average of payment to buy a house, it was like $50,000. An ocean house, 200 meters square. But nowadays, the same house costs like $200,000. It's amazing how increase the prices, but also increase the economy. The salaries also increase it. So the poverty decrease, that it's good, but also people want to have more, feel more comfortable in their health elections. We have in the city, we are more than 1 million people, but now we have a very, 2, 3 more clinics, private clinics, and new ones in the last 4 years. And there are people who goes and pays directly, even if they have an insurance. They go and pays everything. The economy improved, but also they elect the private area, no more than the public hospitals. And with the pandemic, it was worse. They are still afraid to go to the public hospitals or medical center, but we are trying to offer better, comfortable areas in the medical centers, that it's good. And also in the hospital, we improve it with the electronic medical histories that we don't have yet, and now we're starting with that. So it's also good in some way.
Yeah.
Well, I want to thank you both, and sorry to cut you off. If anyone has questions, is it okay if they email you to follow up?
Of course, absolutely. Thank you all so much for joining us.
Thank you for your time. Appreciate it. Good to see you.